Okay, everyone. All right, so we'll go ahead and get started. Thanks for joining this installment of the National Fellow online lecture series. I'm Robbie Bowers at Emory Sports Medicine in Atlanta, Georgia. I will serve as the moderator for tonight's lecture. Before we get started with tonight's lecture, going to plug the next lecture next week, which will be the final lecture of the 2022-2023 academic year. And that's going to be June 21st, next Wednesday, 8:30 p.m. Eastern Time. It will be a CAQ review hosted by Melody Rubish and Jason Zaremski. We will then start back up with the first lecture of the 23-24 academic year, the first week of August. So tonight we have Dr. Erek Latzka at the University of Washington, who will give a lecture on sports hand injuries. Before we get started with that, just a couple housekeeping issues. Again, this program is to serve as an adjunct to your individual program's didactics and not to take the place of any of your educational content over the course of the year with your program. We also want to provide fellows with access to a diverse group of speakers, and mostly AMSSM members, but at times invited guest speakers. And overall, this is really to help you prepare for CAQ exam. Now, as far as tonight, just mute your microphone, turn off your video, put any questions in the chat function. I will then ask Dr. Latzka at the end of this any questions, and we'll have a Q&A discussion after he is finished with his talk. And then also there'll be a link to an evaluation that will be in the chat function as well. So please click on that and provide your thoughts on the evaluation if possible. So again, tonight, Dr. Erek Latzka will be giving our lecture on sports hand injuries. So Dr. Latzka is an attending physician and clinical assistant professor of physical medicine and rehabilitation and sports medicine at the University of Washington. There he's been the director of the diagnostic ultrasound curriculum for the PM&R Family and Pediatric Sports Fellowships. Dr. Latzka earned his MD at Tufts University and completed PM&R residency at University of Washington and an ACGME Sports Medicine Fellowship at Swedish Medical Center in Seattle as well. He's provided medical care across a broad range of athletics, from mass events to professional athletics to collegiate athletics. He is a former varsity track and field athlete at UNC Chapel Hill. And this just happens to be his last week at University of Washington, as he will be moving on to Boston to join Dr. Walter Sussman at Boston Sports and Biologics. So with that said, Erek, go ahead and take it away.
Thanks for having me, Robbie. Just see if I need to share my screen again. Can you see it?
Yep, good.
Okay. Thanks for the intro, and thanks for having me today. It's really hard to separate the hand from the wrist for a lot of these injuries, so I'll be touching on all of them. I have no disclosures. Robbie already touched on some of my training. For those of you who don't know what a sports medicine physiatrist is, because it's come up a little bit recently that some don't, we do 1 year of internship in internal medicine, followed by a 3-year residency. And those 3 years include at least 13 months of inpatient coverage with patients with TBIs, SCIs, polytrauma. And then, as you probably know, we do a sports fellowship and take the same CAQ as family, as emergency. So that's a little bit about that. And he also touched on my career. I've been at UW now for 5 years, and I'm leaving to go back home to Boston with my family, and lucky that I got a good job working with Dr. Sussman. Wouldn't be here without a lot of great mentors, both in residency, in my career, and in fellowship, and also the my trainees that I've had in the last 5 years have made me a much better doctor as well. Bigger thanks to my wife for letting me do this lecture and letting me always do these extra things. I think she's getting sick of them, especially this week as our house is being packed and we're on the way. I'll try to get home soon. There are a lot of other lectures that have been done recently on these injuries and in more depth and detail, so I would recommend looking at some of them. We're going to be covering so many that they will be much more superficial, but we'll try to touch on all the high yield stuff that might be on your CAQ. So to form this lecture, I reviewed books like these and basically took out any diagnosis that might come up on your test next month. It's only a month away, so I assume anything that's not highly relevant for that exam, you're not going to be paying attention to. This is the outline for these injuries. There's about 40 of them. So in about 40 minutes, I'll try to touch on all of them. And we'll start with the distal forearm and the TFCC, or triangular fibrocartilage complex. This can be injured in various locations, but we'll focus on the articular disc first because this doesn't create any instability in the disc. The articular disc is injured with acute falls on outstretched hands, or it can be chronically injured with repetitive ulnar deviation in sports like tennis, baseball, and gymnastics. Here we have a combination of those two, with Mike Trout sliding into second base and tearing his TFCC. On exam, the shear or dorsal glide test is the one that's tested most often, with opposing dorsal and volar forces over the piece of form and ulnar head, recreating the pain and recreating kind of a clicking sensation. There are various other physical exam tests that all act to load the TFCC through ulnar deviation, wrist flexion, and extension, but the shear and dorsal glide test is the one that's most commonly cited. From a diagnostic standpoint, here we have an MR arthrogram in the upper right hand, the screen. It's comparable to 3T MRI. Still, arthroscopy is the gold standard when it comes to tests. X-rays can show a positive ulnar variance, so the ulnar head a little bit more distal to the radius, but otherwise, ultrasound, while you can see a tear, as I've shown here, it's not a good screening tool. It's very operator dependent, and this is a very hard image to get. So if you do see a tear of the articular disc on the TFCC, a neutral splint for 4 to 6 weeks, followed by physical therapy and or a corticosteroid injection can be helpful. Repair is really more for the peripheral tears of the radial ulnar ligaments, and we'll talk about those in a little more detail when we talk about drudge injuries. And then ulnar shortening can be done if there's positive ulnar variance, and that's done more often in the case of ulnar abutment syndrome, and we'll talk about that as well. So if you're concerned about stability of this joint, the distal radial ulnar joint, the piano key sign or the Blotman test is the one that's kind of classic. So you push down on the ulnar head and it should basically spring back up proximally once you release it. And that's indicative of a radial ulnar ligament tear. If we go back to this image here, those ligaments are the ones at the edges, both volarly and dorsally. So X-rays can show a widened joint, and MRI can show a tear in the radial ulnar ligament. These are more often repaired or reconstructed, but if you do attempt non-operative treatment for a drudge injury, you want to use a long sugar tongue cast to prevent supination and flexion, supination and pronation of the wrist. One other thing that comes up on these tests is if it is combined with a distal radial fracture, that's called a Galeazzi fracture dislocation. Ulnar abutment and impaction syndrome will present similarly with ulnar-sided pain, but usually in older athletes, more degeneratively, more chronically. It has been reported in some younger boxers and MMA fighters, but your exam is pretty similar to what you see with your TFCC tears. From a diagnostic standpoint, you should see a positive ulnar variance as demonstrated here, but your MRI is really what's going to differentiate it when you see signal in the lunate, signal in the triquetrum, or in the ulna itself. And later in the disease process, you can see subchondral sclerosis and subchondral cysts. The treatment for this is an ulnar head resection or shortening procedure. Distal radius fractures have been covered extensively by Dr. Lieber already. I'd recommend looking at that lecture. It was great. What you should know, at least for the test, are the differences between Colley's, Smith's, and Barton's fractures. And it is, there are a lot of nuances to when these are treated surgically versus non-surgically, but to make it as brief as possible, non-displaced extra-articular fractures are going to be treated with splinting until the swelling resolves, followed by a cast. Any of the other things, so displacement, comminuted, intra-articular, highly angulated, ulnar fractures, drudge instability, nerve injuries, those more often go to surgery. This came up in my review. It's a little bit proximal to the wrist, but I didn't really know what a green stick fracture was, so I thought I'd throw it in here. It's basically a bend of the bone in pediatric patients where the cortex remains intact on one side. So these are treated with casts and splinting, and they heal very well. Finally, the distal radial epiphysitis or gymnast wrist. This is unique to athletes during growth spurts who are doing a lot of repetitive axial loading of an extended wrist. So that's primarily gymnasts who are performing over 35 hours of practice per week. Weightlifters have also been reported. The exam is non-specific, and so you need to have a low clinical or a high index of suspicion and a low threshold for imaging. You want to get at least an X-ray with bilateral views so you can compare this to, to the normal side. And if inconclusive, have a low threshold for getting an MRI, because this isn't something you want to miss. If you allow the athlete to continue practicing and competing, it can lead to early growth plate closure, more positive ulnar variance, and even a shortened radius called a Madelung type deformity. Moving on to the true kind of carpal region. First, we've got carpal ganglion cysts. So most often these are dorsal. There's have been a few papers in the last few years saying that we might be underestimating volar volar ganglion cysts, but the texts will, thus far always say that dorsal is more common, and the most common location is coming from the scapholunate joint. Usually, and early on, they're painless and asymptomatic, but as they get larger, they can limit wrist extension and become painful. In that case, an ultrasound or MRI can be useful to make the diagnosis, or at least confirm the diagnosis. I've seen plenty of what were sent to me as ganglion cysts ended up being various other things, and tumors and tendon tears and retractions. So always, don't just go aspirating it before you've confirmed with an image. If it is symptomatic, though, aspirating it and doing a corticosteroid injection is helpful. Surgery is warranted if it recurs. And here, we've got one video here of just showing how this dorsal ganglion cyst tracks from the scapholunate joint. There's the stalk going right to the scapholunate joint. And those can occur with partial tears in the scapholunate or full tears. So the scapholunate ligament, and you're going to see a similar theme. A lot of these are injured with the same mechanism. So an acute Fuchs injury or a chronic axial loading during wrist extension. Now this occurs with a axial loaded wrist in ulnar deviation. So weightlifting, especially people who perform front squats or under heavy weight. There's tenderness palpation distal and ulnar to Lister's tubercle with a positive Watson's test. So the examiner is taking the patient from a ulnarly deviated to a radial deviated position while applying pressure to the scaphoid. If that reproduces a click and pain, it's positive. On X-ray, you're really only going to see a positive Terry Thomas sign if you have a full ligament rupture. You're not going to see that with a partial rupture. If you suspect, if your clinical suspicion is for a scapholunate tear and your X-rays on bilateral clenched fist grips look normal, I would recommend at least doing an ultrasound. If you're not comfortable with ultrasound, getting an MRI to look for a partial tear. Because those partial tears can be treated with splinting, like a neutral wrist splint. They can be treated with corticosteroid injections or PRP. But typically the textbook, especially if you get a question where you see widening of the joint, those are going to be treated with open surgical repair. And that is that's to prevent things such as DISI and slack. So what those are is, as these ligaments tear, the bones start to move, and the scapholunate angle can increase from 30 degrees. Once it increases beyond 60 degrees, That's called DISI, or dorsal intercalated segmental instability. And once that happens, you can have SLAC, advanced collapse of the advanced collapse osteoarthritis. And this is another video showing that process where the capitate moves proximally from that instability. The Lunotriquetral ligament is the next ligament. It's again with axial loading during wrist extension, but now with radial deviation. Ulnar pain. So this is going to present similar to our ulnar abutment, TFCC injuries. And there's even a kind of similar test, the Kleinman shear test, where you use opposing dorsal and volar force over the pisiform and lunate, as opposed to the ulna and the lunate, or ulna and pisiform, excuse me. And then there's another test called Reagan's ballottement or shuck. They have a lot of names, these tests, but they all basically involve moving the lunate while either stabilizing the triquetrum in Reagan's or moving the pisiform and triquetrum together in Kleinman's. MR arthrogram can show some extension of contrast outside of that ligament. Arthroscopy, though, is the gold standard. And in this case, it doesn't lead to DISI, or dorsal instability, it leads to volar instability. And this finding of DISI can be found in some normal hypermobile patients, so it's not always pathologic, unlike DISI, which is. This is one of the more interesting, I think, diagnoses that you might be tested on, and one of the trickier ones. So a perilunate dislocation is not a lunate dislocation, and so differentiating these two things can be helpful. They both occur with similar mechanisms. So high velocity FOOSH injuries, usually motor vehicle accidents that cause hyperextension and ulnar deviation. They are not common, and oftentimes in the emergency room, they can be missed at presentation. The symptoms are pretty vague, with wrist swelling and some carpal tunnel symptoms, so they might be sent home with presumed carpal tunnel. And lateral x-rays, if you don't have these nice labels, they can be hard to see and easy to miss. So on a lateral x-ray, a perilunate dislocation is the dorsal displacement of the capitate, while a lunate dislocation is the volar displacement of the lunate, and that's sometimes referred to as a spilled teacup. So you can see in this position, it's a teacup that could be filled and not spilling, and then here it's tipped over. CTs are often indicated for both of these injuries to rule out concomitant scaphoid fractures. And both of these are usually repaired with open reduction and surgery urgently, especially the lunate dislocation. And this is something you want to take away from this talk, that this is very, you don't want to miss this lunate volar dislocation because it's going into the carpal tunnel. And if you miss it, then you can have a median nerve injury. And let's see here, Kienbock. So this is a vascular necrosis of the lunate. You can see on the picture here, just of an x-ray, you have some sclerosis of that lunate. This occurs in males 20 to 40 years old most often, but not from high velocity trauma or FOOSH injuries. It's more from just chronic, repetitive, minimal trauma. So just regular people out there playing golf, playing football. They present pretty non-specifically too, with just tenderness to the lunate. And x-rays, especially early on, might not show this sclerosis or flattening of the lunate. More advanced cases will show fragmentation and collapse. So if you can't figure it out and the patient continues to have this dorsal lunate pain, MRI is the gold standard. So they probably will have gone to physical therapy before that. And if they're not improving, get the MRI. This one thing that can clue you in on this disease is associated with negative ulnar variance. So if the ulna is below the radius or proximal to the radius, there isn't another injury that is associated with the negative ulnar variance as far as I know. So this distinguishes it from impaction syndrome and TFCC tears. The scaphoid fracture is what kept UNC from winning the 2012 national championship, I think. It is a fouche. The mechanism is, again, a fouche, and it's the second most common wrist fracture. More common in young people than older, and that's because if an older person falls on an outstretched hand, they're more likely to fracture their radius, and that gives before the scaphoid does. On exam, while we always talk about tenderness to palpation at the snuff box, the exam's kind of unreliable, and x-rays are also unreliable. So if the story fits and the location fits, and there's any palpation, any tenderness to palpation at the snuff box, I would get an MRI. And you may want to get one with IB contrast if you're at all concerned for a proximal pull injury, and we'll get to that in a second. So a stable injury, meaning it's non-displaced, can be treated with casting and a thumb spica splint for about 3 months. But if there's any more displacement than 1 millimeter, you're going to have to surgically fix that fracture. If you want to get an athlete back faster, and a lot of pro athletes will do this, they'll have their surgery and then they'll get a cast, and they'll come back before they're fully healed, and just rely on the cast to protect that bone. The important part, though, to scaphoid fractures is where the fracture occurs, because the scaphoid is getting its blood supply distally. And so if you fracture, you're not going to get proximal flow, or flow proximal to the fracture. Fortunately, most of these fractures are waist fractures, so fractures that occur kind of in the middle of the scaphoid. The ones that occur in the proximal pull are the ones that are most likely to lead to avascular necrosis or non-union. So just have if you see a proximal pull fracture on your x-ray, I would also get, that's when I would definitely add IB contrast to see if there's any early AVN already occurring. Wrist guards in snowboarding and skateboarding have been shown to be preventative of scaphoid fractures. The hamate hook fracture, or a type 1 hamate fracture, occurs with an acute swing of either a golf club, a baseball bat, hockey stick, and it presents as kind of a vague pain and tenderness at the volar ulnar aspect of the hand. It can also be associated with some ulnar neuritis given the hamate's proximity to Guillen's canal. And the main exam finding that you guys should know about is the hamate pull test. So essentially what the examiner is doing here is applying pressure to the area of the hamate while resisting flexion of the 4th and 5th digit. In ulnar deviation, this is painful, and in radial deviation, it's not. And that's because in ulnar deviation, these tendons of the FDP tendons are basically rubbing up against the hamate. And in ulnar deviation, in radial deviation, they aren't. So for diagnostics, this carpal tunnel view is the only way to really confirm it on x-ray, and that can often be missed. CT is better, unless we're talking about a stress injury, and that's a different presentation. We'll get there in a second. So if you do see a CT, on CT you see a fracture, there's a little debate about how to treat them. They can be treated just with rest conservatively or surgical fixation, but either way, if they recur, the hamate hook is often excised or recommended to be excised. Now, one other way this can present is in rock climbers who have a slow, subtle onset of worse and worse ulnar palmar pain. And this is in rock climbers who use an undercling grip. So this is kind of an advanced grip, but it highlights the path of the FDP tendons and how that position puts stress on the hamate. If you have this kind of pain in a rock climber, I would suggest getting an MRI, because just like a stress fracture, if there's not a true fracture line, you're going to miss it on other imaging. De Quervains, or first dorsal compartment tenosynovitis, involves the APL and the EPB. It occurs in athletes who are golfing, fishing, playing tennis, rowing crew, and even in esports. The exam maneuver to test for it is Finkelstein's. So basically holding the thumb in a clenched fist and ulnarly deviating, reproducing pain at the radial wrist. That is more accurately called Eichhoff's test, but everyone talks about it as Finkelstein's, and I'm not going to get into that. I think either of those would be correct on a board exam. From a diagnostic standpoint, ultrasound is very useful if you have it in the office. Both it and MRI can show a thickened retinaculum. And here we have one that's 0.16 centimeters. That's about 3 times as large as normal. And then it can also show tenosynovitis of the retinaculum or tendon sheath. This is a little debate. I don't know how to tell you guys what the answer is going to be for first line treatment for the Quervains. In a lot of textbooks, it'll say rest and immobilization. And I can tell you in at least a few other exams that I've taken in my career, the correct answer has been corticosteroid injection first line. And that's based on a study that showed an 82% cure rate back in the 90s. And some studies have shown even higher than that. In my clinical practice, that's what I do. First time I see it, I do a corticosteroid injection with ultrasound guidance. But it could be either of those based on this test. I'm not sure. Other things you should remember, though, that the APL and EPB can either share a sheath or they can travel in separate sheaths. So if you do an injection, you need to look for that possibility to make sure that your flow is going into the symptomatic tendon sheath. It's the most common tenosynovitis in athletes and in new moms, at least involving the wrist and hands. Proximal intersection syndrome was just presented by my fellow Malia Kali a few weeks ago. So I stole most of this from her. It presents after repetitive wrist extension. So classically in crew, but can also occur in weightlifting and racket sports. There's tenderness to palpation in the area of the intersection, about 4 centimeters proximal to Lister's tubercle. And some people will describe a crepitus, and they'll describe it actually more as like a squeaking. So I think some people will term this even as a squeaking wrist, and that you can even hear audibly. I've seen that once. On ultrasound, you can follow the compartment. So here we have the first passing over the second. And you can also look with Doppler to see if there's tenosynovitis in that region. On MRI, what you'll see is this increased signal peritendinous edema. And this is also like the Quervains, treated pretty well with the corticosteroid injection in between the at this intersection point. I don't know of anyone doing surgery for this procedure, or even what that surgery would be. Distal intersection syndrome involves the second and third compartment. So we're moving now distal to Lister's tubercle. It's more in drummers than athletes, although I would say drumming requires a lot of athletic stamina and strength. It can also be found in esports, cheerleading, and tennis. The tenderness is, like I said, distal to Lister's. Also can have that squeaking kind of crepitus, and there will often be pain-inhibited weakness on thumb extension. Similarly, you can use ultrasound to follow the third compartment, which is the EPL, as it passes over the second compartment here. This is in a normal patient. Or you can get an MRI to look for these peritendinous edema in those second and third compartments. This again is treated with kind of conservative measures, rest, spica-splint, and corticosteroid injections. However, if it's recurrent, synovectomy is recommended, and in chronic cases, it can lead to a rupture of the EPL, which is not a good injury to have, especially in a drummer. ECU tendinopathy and or subluxation. This is the 6th dorsal compartment. It's common in racket sports, club sports, high impact sports. You guys probably know, the easy things are there's going to be tenderness along the ECU pathway. There's going to be pain with wrist extension and ulnar deviation. But the one exam test that's cited in a lot of the textbooks is the ECU synergy test, which is essentially resisted abduction and adduction of the first and second digits. And that reproduces pain at the ulnar, at the ECU. Now this ECU, if it's subluxing, should sublux with supination and reduce with pronation. And MRI is not going to show that unless the tendon is subluxed while the image is taken. Ultrasound can be more useful because it can show dynamic subluxation. If you do confirm that and the patient has already tried conservative therapies, an ECU subsheath reconstruction may be recommended, which is basically where they recreate this ligament here to hold the ECU down. And if this occurs in a young person who's not an athlete, you need to think about rheumatoid arthritis and other inflammatory disorders. We all know a little bit about carpal tunnel syndrome at this point. The takeaways are this happens in gymnasts, weightlifters, cyclists, rowers, and wheelchair athletes. So all of those people are using their wrists extensively. Exam maneuvers, I think you guys know already. I think the one key always is that the numbness should only involve half of the fourth digit. It should not go on to the ulnar side of the fourth digit. EMG and nerve conduction studies. I think there was just a great lecture by Dr. Herman recently. And from an ultrasound standpoint, this is what a normal carpal tunnel looks like with the TCL over the top, going from the pisiform to the scaphoid, this honeycombed appearance of the median nerve. I hope you guys can see my arrow, or if you can't, Robbie, let me know. I'll stop using my arrow so much. The things you can see on ultrasound, though, in pathologic or in carpal tunnel syndrome are an increased cross-sectional area. That's the main one we look for. And so here's one in a patient who's got about almost 3 times a normal cross-sectional area. I don't expect them to test you on what the normal is. It's around 0.09, but knowing that an increased cross-sectional area is indicative of carpal tunnel syndrome could be on it. Positive notch sign is basically looking at the nerve in long axis and seeing that its thickness decreases by about 50% under the TCL. I think you guys know that treatments of neutral wrist bracing during activity or sleep, corticosteroid injections for temporary relief, and carpal tunnel releases, either on the textbook, probably open or endoscopic, but more recently ultrasound guided, shown to be just as good. These can occur, as I've already pointed out, with lunate dislocations, and in that case, it's a surgical kind of emergency. Cyclist palsy involves the ulnar nerve at Guillaume's canal. It's from handlebar compression, but can also occur in weightlifters doing heavy bench press or wheelchair athletes. This, again, will involve the ulnar aspect of the fourth digit as opposed to carpal tunnel syndrome. EMG and nerve conduction studies are indicated. Ultrasound can be helpful. You can differentiate the TCL and volar collateral, the volar carpal ligaments as well. You can follow that Guillaume's canal from the proximal carpal tunnel to the distal aspect where the nerve splits into its superficial and deep branches. This is useful if a patient's not getting better or presenting with weakness, because sometimes you see things like this. You can see hamate fractures, you can see ganglion cysts. This was I think a racquetball player in what I saw in fellowship, and we just drained the ganglion cyst and it didn't recur and their strength improved. So it was an easy fix, fortunately. The typical treatment, though, if you're not seeing a cyst like this, is a bike fit to make sure they're not putting too much load on their upper extremities. Gloves, padded gloves, changing the handlebar grip. And if there is progressive motor loss, then surgical decompression. The next neuropathy we'll talk about is Wartenberg syndrome. This is really just a pain and paresthesia problem. It's not going to lead to weakness, fortunately, because it's a palsy of the superficial radial nerve. This occurs in athletes wearing tight wristbands, weightlifting bands, or $5 million watches like Nadal is here. The Tinel test at Wartenberg's point can reproduce the symptoms. And interestingly, Finkelstein's test can be positive too. And that's not because you have de Quervains. That's just because doing this is putting neural tension on the superficial radial nerve. So if you have a positive Finkelstein, and they say, oh, that reproduces my tingling or numbness, think about Wartenberg syndrome. This is usually a clinical diagnosis. The treatment is removal of the compression, and it usually does really well, rarely requires injections or surgery, but it's important to differentiate it from your de Quervains and your intersection syndromes. Moving on into the palm in the hand. The first thing we may see, and very commonly in our older athletes, is CMC osteoarthritis of the trapeziometacarpal joint. This can present with pain kind of throughout the palm, on the radial aspect at least. It can be volar, dorsal, or radial. It can cause pain with any kind of movement of the thumb or gripping, pinching, especially. The CMC grind test is the classic one where you apply an axial load to the thumb and you're basically pushing down and rotating. I've had residents suspect that patients have had dislocated thumbs before for this. So if it's enlarged enough, it can actually look like it's dislocated and out of the joint. X-ray is all you'll need for the diagnosis. Early on, a spica splint or corticosteroid injections can be done, but if you get to this severity, a arthroplasty or metacarpal kind of resection can be helpful. And if it's a young patient with this, you want to consider inflammatory disorders. Metacarpal thumb fractures, the first we'll talk about is the Bennett fracture. And this occurs with force abduction. So often in football players or in probably more MMA athletes than boxers. But I think the textbook says boxing. Now, exam-wise, pretty non-specific, swelling and limited range of motion, but your x-ray, you want to pay attention to that proximal aspect. And this is a non-comminuted fracture. If it's comminuted or more than 2 pieces, then 3 pieces or more, it's going to be a different type of fracture. So for this, closed reduction can be attempted plus a spica brace, but most are going to need open reduction and internal fixation. This is a high rate of osteoarthritis afterwards. Rolando fractures are essentially the same fracture, but now comminuted. And this is much more common in men at a 10-to-1 ratio. And that's because the typical mechanism is a fist fight. And it's always treated with surgery, and it has a much worse prognosis for CMC arthritis and disability down the road. Moving more distally, shaft fractures can be categorized into 2 ways, either transverse or oblique and spiral. Now, there are some similarities between these and some differences. So a transverse fracture tends to fall on a clenched fist or a blow to a helmet, while oblique or spiral fractures falls onto an open hand. So here we have Steph Curry falling onto his open and ulnarly deviated hand, and he suffered, I believe it was can't remember if it was oblique or spiral. So that can occur with twisting of hands as well during sports like wrestling. The main things to pay attention to are to look for shortening of the metacarpals, in which you will lose essentially a knuckle, or for malrotation of a digit, where all of these digits should be pointing to a common scaphoid location. And if there's overlap, that indicates rotation, which is a surgical indication. If there is no high degree of angulation or rotation, then you can try to treat with buddy taping and splinting. But if it's unstable or if there's rotation or shortening, then often surgery will be needed. These are some images of these. So the x-ray of the transverse fracture, not hard to see. X-ray of the oblique fracture, also not hard to see. But the spiral fractures, if they're non-displaced, those can be pretty subtle. So if you have the right history, just make sure you look closely. Metacarpal neck fractures, moving a little more distally. Again, these occur with fist fights and punching, now in a 20-to-1 ratio of men to women. There is some dorsal angulation of the metacarpal on x-rays and can also be seen on exam. You should again look for the loss of the knuckle. And the most commonly known one is the boxer's fracture. That's at least what it's called. It's when, as was shown in these x-rays, the fifth metacarpal neck has a transverse fracture that's non-comminuted. Interestingly, though, boxer's fractures are not usually seen in boxers because boxers throw punches and try to strike with their second and third knuckles and digits where they can get more power. It's really street fighters or non-trained fighters that strike with the outside of their hand, which is a weaker area and more likely to injure. So it's kind of paradoxically named that most boxers injure their second and third metacarpals and not sustain boxer fractures. Lumbrical tears, these are found in the third and fourth lumbricals. And the reason for that is because they originate off adjacent tendons. And in this, because they originate off adjacent tendons, this specific grip in rock climbers is called a pocket grip, where one finger is extended and the adjacent fingers are fully flexed, causes a shear force on this muscle, and the muscle stretches and tears. Now, this you kind of just have to know by history and have a low threshold for or a high index of suspicion. If they come in with palmar, mid-palm pain after doing this grip, this has got to be high on your differential. And as long as it is, you'll know to do an exam maneuver that's really only going to test the lumbricals, and that's passively fully extending one finger and fully flexing the others. So if you do that passively and that motion reproduces the pain, there's not too many other things. It's you've pretty much made the diagnosis. Ultrasound can show a tear. So here's a torn lumbrical distally versus a intact lumbrical, and then here's the lumbrical with this is, I think, a chronic injury, so it had a lot of muscle belly loss distally compared to the normal ones adjacent to it. The key with lumbrical injuries is you just want to make sure they rest and don't continue to climb, and that they maintain their range of motion, because these can scar and cause a flexion contracture. And finally, to the fingers. So skier's thumb, starting at the MCP joint. This is a abduction injury, typically in skiers who are using poles and who fall onto their poles, or in wrestlers who, that when you're trying to get your opponent's hand off of you and peel it off, they're pulling their hand back by their thumb. So after you've done an x-ray, if you have a history for an acute abduction injury in a skier or wrestler, I would advise get an x-ray early to rule out fracture. Once you know there's no fracture, then you can do some stress examinations. And this abduction stress should be done in both full extension and full flexion. And that's because these positions of flexion and extension test different parts of the ulnar collateral ligament. And if you only do it in flexion, you're going to be missing, you're not going to be testing the entire ligament, and you might get a false positive. So once you have your x-ray and you've done your exam, it is kind of useful to get an MRI or ultrasound early to rule out a Stenner lesion. And that's because Stenner lesions are really common in these injuries. I think some studies say up to 50 to 70% of UCL tears involve a Stenner lesion. And that's when the UCL tears distally and kind of retracts and gets transposed by the overlying adductor aponeurosis. So this is the adductor aponeurosis here. This is the short axis of the aponeurosis here. And this is an intact UCL and an intact adductor aponeurosis over the top. And then this is a torn UCL retracted, now a center lesion. And there's no way that this is going to get back down here because the adductor aponeurosis is preventing it from doing so. And you can see that more clearly when I remove the labels. So a spica cast and then a spica splint can be used to treat if it's stable and if there's no Stenner lesion. But if it's unstable, if there's a Stenner lesion or an avulsion fracture, then open repair is recommended. And gamekeeper's thumb is essentially just the chronic presentation of this injury. A skier's thumb is the acute presentation. boxer's knuckle, not to be confused with boxer's fracture. This is seen in boxers and also other martial artists. It typically involves the middle knuckle because that's the one to strike first. And it's a tear of the sagittal band. The sagittal bands are what hold the extensor tendon in place dorsally. So here you can see the sagittal band that's displaced ulnarly. It can be diagnosed just on your exam with flexion and extension of the fingers. You should be able to see this tendon go from midline on the finger to either ulnar or radial. MRI can also diagnose it, and so can ultrasound. And ultrasound can show it dynamically. So if you do make this diagnosis, you want to put the patient in an extension splint for 6 weeks. If it's recurrent and chronic, then sometimes they're treated surgically, but most of the time they are not. And again, don't confuse it with a boxer fracture. Boxer's knuckle is a ligament injury. Moving a little more distally, we have volar plate injuries or volar plate tears. Typically, these occur at the PIP joint more so than the DIP or MCP. They're from forced hyperextension, so a basketball kind of hitting or a volleyball or any kind of ball suddenly hitting the finger and hyperextending it. On exam, there's no endpoint on passive extension. And from a diagnostic standpoint, MRI or ultrasound can show the tear. X-ray can show an avulsed fragment, as it does here. And there are different ways of classifying these fractures, whether they're associated with dislocations or if they're just associated with fractures. This might be a little beyond what you need to know, though, for boards. If there's an avulsed fragment that's greater than 40% of the articular surface, though, that is going to require surgery. If it's less than 40%, then an extension blocking splint is appropriate. Now we're going to move to dislocations, starting with MCP, then PIP, and DIP. All of these, we're going to focus on the dorsal dislocations because that's the most common one. Volar dislocations and all of these are very rare, so we're just going to skip them. Dorsal dislocation of the proximal phalanx. It occurs after forced hyperextension. On exam, that digit is still going to hyperextend at the MCP joint. You can see overlapping of the digits, which you don't really see here, but you do see they're closer together, and you see some puckering of the skin here on the palmar side. On X-rays, make sure you pay attention to your lateral and obliques, because on your APs, they can be easy to miss. This is of a thumb, so it's not easy to miss, but of the second through fourth digits on an AP will be easily missed. These are treated with open or closed reduction and splinting for 6 weeks, blocking the last 30 degrees of extension. If the dislocation is complex, meaning the volar plate gets torn and lodged in the joint, or a sesamoid bone gets lodged in the joint, then they might be irreducible, and those will require surgery. At the MCP level, this is an uncommon injury. PIP dislocations are much more common. Here's Steph Curry's a few years ago. This occurs, again, jammed fingers catching or hitting a ball. The exam can show a swan neck deformity. This is an acute swan neck deformity with PIP extension and DIP flexion. And try to always ask or see if there's a picture, or because the direction of the dislocation can tell you what ligaments are going to be injured. Diagnostically, get X-rays early to eval for an avulsion fracture. If there's an avulsion fracture that is small and the joint is stable, then you can do a closed reduction and buddy taping. And but the volar dislocations, like I said, those are more rare and oftentimes irreducible. Finally, DIP, dorsal dislocations. All of these, again, hyperextension of the joint, mostly when balls are hitting fingers, and always obtaining X-rays to rule out avulsion fractures. These are more easily treated. Traction, just manual traction plus flexion can usually reduce them, and they only need to be splinted for about 3 weeks. Jersey finger, on the other hand, is not easily treated. This is a tear of the FDP tendon. It occurs when grabbing an opponent's jersey or in open hand, open grip rock climbing. There's usually a sudden pop felt and acute pain. Patients present with the inability to flex their DIP joints, which is why he's extended at the DIP here, but FDS flexion is intact. So X-ray should be obtained to eval for avulsion fractures, which are common, and there are a lot of different types, and there are 6 types of FDP tendon tears, depending on how far the tendon retracts to, or if there's an avulsion or not. That might be a little beyond what you need to know for your CAQ, but it is important to at least get the images to assess for those things. So you want an X-ray to look for the fracture, and you want an MRI or ultrasound to eval for tendon retraction, because this is going to go to surgery, and the surgeons are going to want to know how far that tendon's retracted. It's also called rugby finger. Mallet finger or mallet fracture is a terminal extensor tendon tear at the distal phalanx. So this is, now we're getting a hyperflexion injury, or a flexion, a resisted, a passive flexion against active extension injury. It occurs in basketball, football, baseball, and patients present with the inability to extend their DIP joint. This was Russell Wilson a few years ago. Lateral X-rays are important to look for that avulsion fracture. Most of these can be treated by splinting in extension for 6 to 10 weeks. And if you do that, you need to allow the PIP joint to still have free range of motion. But if there is a fracture that involves over 40% of the articular surface, surgery is the treatment. Kobe played a full season with one of these, just taping it, I think that was in 2009 or 10. And if not treated, this can lead to a chronic swan neck deformity, as opposed to an acute one that we saw in the PIP dislocation. The other extensor tendon injury is a central slip tear. So this isn't a tear at the terminal tendon. This is a tear at its insertion onto the middle phalanx. Again, it's similar theme here. Struck by a ball is flexion against resisted extension, and they present with the opposite of a swan neck deformity. So now you're seeing PIP flexion and DIP extension. The board test, or the board one that's on the boards often, is this Elson's test. So the patient's fingers are gripping over a table with flexion at all of the PIP joints, and then the symptomatic finger is attempted to be extended against resistance. That's called Elson's test. X-rays are important to rule out avulsion fractures. If it's an acute injury, it can be splinted as long as it's not displaced over 2 millimeters. And chronically, though, they'll require a serial casting to get them out of their boutonniere's deformity prior to surgery. This is just a brief summary on the different deformities that I've mentioned so far. I think the takeaway from this is that boutonnieres and mallet deformities are pretty clear and occurred usually from just the same injury every time. Swan neck is a little more complicated in that there can be an acute presentation of it with dorsal PIP dislocations and molar plate tears. There's a chronic presentation of it with the untreated mallet finger, and there's also commonly atraumatic presentations of it in patients with rheumatoid arthritis, psoriatic arthritis, and lupus. Trigger finger is an injury that it's more often not in athletes. It's just in our aging population that works with their hands, but it can occur in athletes that are involved in racket and club sports and rock climbing. It presents with tenderness at the volar aspect of the MCP joint. The classic, that everyone knows, is just the catching, the inability to extend from a flex position without passively kind of forcing it open. The way to diagnose this, I think clinically is enough, but ultrasound can show a thickened A1 pulley. So here we have a normal A1 pulley, and here we have a thickened A1 pulley. And this is in short axis on the finger, the long axis on the pulley. It'll also show tenosynovitis in this area of the pulley and the tendon sheath. So first line treatment, you can try splinting, but oftentimes corticosteroid injections in this area will be very helpful, especially if you see tenosynovitis like this. Ultrasound guided or surgical releases can also be done for recurrent cases. However, this might not be in any textbooks, but I would not recommend a ultrasound, any kind of release in a rock climber for the A1 pulley, because you take away that A1 pulley and all of that force is now going to be transmitted to the A2, A3, and A4 pulleys. I've seen that happen with patients who've had A1 releases and go back to rock climbing and then suddenly have 2, 3, and 4 ruptures and require surgery. A2 pulley ruptures, speaking of that, are injured in rock climbers in specific crimp grip, which loads the A2 pulley and puts a lot of force on the PIP joints. They present with a pop felt during this position and tenderness to palpation on the volar aspect of the proximal phalanx. They'll have pain with resisted finger flexion, and ultrasound will show this classic kind of bowstringing of the tendon. That is measured as tendon phalanx distance, the distance between the tendon and the bone. Now, that's bowstringing you can see on a dynamic ultrasound. You can also see it on MRI. Clinically, it's rarely seen. The only way you're going to see bowstringing by looking at someone's hand is if they've torn their A2, A3, and A4 pulleys, and that's more rare. So these are classically treated just with rest, a thermoplastic ring to help hold the tendon down to the bone while it heals, and surgery if you have an A2 and A4 rupture at the same time. The A4 pulley rupture occurs in a different kind of grip, the open hand grip. It's also been reported in a major league pitcher as well, but it's an acute pain or pop. And it can also occur in the same mechanism as jersey finger. Tenderness palpation will now be at the middle phalanx volarly, and there will still be pain with resisted FDP flexion, but not with resisted FDS. Ultrasound will show an increased tendon bone distance here and here. This is normal, this is torn. And the other thing you can take away from this is the tendon is very straight and horizontal, running from proximal to distal, whereas here it's depressed by and held down by the overlying pulley. Again, same treatments, rest, thermoplastic rings, taping, same indications for tears, only with multiple pulley ruptures. Nail bed injuries are from trauma or crush injuries. The nail bed can appear bruised, swollen, lacerated. There's all sorts of presentations with this. Adjacent cysts called myxoid cysts can occur. The key, though, is to get an x-ray to look for a fracture, and don't jump right to draining this. Ultrasound can also show injuries to the nail matrix that you don't see, that's deep to the nail. And the typical treatment, once you've ruled out a fracture, is aspiration of this with a needle. And if there's a laceration deep to the nail might actually have to be removed to suture it and then replaced. If there is a fracture with the nail bed injury, those will require antibiotics because of high rates of infection. But I think the main key here is don't drain before ruling out a fracture, because if you do, you're turning a closed fracture into an open fracture. And there's one other injury called a Seymour fracture, and that's when you have a mallet deformity from a growth plate injury and nail bed injury. That's pretty rare, I believe. And I think this is our last diagnosis on the list, Volar's thumb. It's a digital neuropathy that's common in Volar's from compression by the thumb hole. And it's the medial digital ulnar nerve of the thumb. And you can have a positive Tenella sign at that area, numbness, the first web space, and this palpable mass, and the mass is the neuroma, because the recurrent chronic trauma to this area causes perineural fibrosis, which can be seen on MRI, this thickening here, or on ultrasound, this thickening here. These are treated well with kind of conservative treatments, resting, thumb guards, or changing your grip to be less deep, I guess, and more in the ending at the IP joint. But essentially, it's very similar to a Morton's neuroma, just up the thumb. Those are a lot of diagnoses we covered. So trying to wrap my head around all of them, it can be difficult. So this is just another way to think about it. Ones that are common for which sports, and then the other way to think about it is, where do these certain things present in what part of the hand, how far distally, dorsally, ulnarly, radially. Those are my references, and I'm sure, hopefully, we have some time for questions.
Awesome, thanks, Erek. That was impressive that you covered. When I saw the list of the number of diagnoses, I was like, "There's no chance we covered this in an hour." So, good job. I can be confident that I think if any of the fellows or anyone researching that has a question on wrist or hand pathology, specifically hand, on their test, that it was just covered in this talk. So solid job going over everything. You have one question in the chat as of right now. If anyone else has questions, please put it in the chat function now, and we'll go through. So question is from Evan. Looking at the ultrasound of the nail bed injury, can the concerning findings be explained a little more extensively, what to look for in the injury to the matrix?
Yeah, so I had some other images I didn't put in here. So one thing you can often see here, you can't see this part of the nail, right? Because it's covered by skin. So that can allow you to see if there's like a fracture in the nail bed. And you can, oftentimes you'll see cysts and fluid tracking out of it. That's what can form what's called a myxoid cyst. You can also see fractures of the bone deep to the nail bed on ultrasound, if you haven't yet, gotten your X-ray.
Okay. Do you have a sense of, and I don't know the answer to this question either, how much, I just can't recall from our test, which is now 5 or 6 years ago, how much ultrasound for some of these kind of wrist hand pathology, how much ultrasound has permeated into the test as far as an option for diagnosis. I'm still not sure how much ultrasound has gotten to this point beyond from a diagnosis standpoint.
Yeah,
I think there's some.
I can remember.
Yeah, go ahead.
I think if a question's giving you options, probably with MRI and ultrasound, I'd probably go to be safe with MRI, but there might be some where they just give you ultrasound as an option and don't put MRI in. And in that case, I can remember that I think the Quervains has been commonly tested with ultrasound. Obviously, ganglion cysts. There are certain things that they're going to say can be diagnosed without an MRI. Scapholunate, I think that's probably more my personal choice, and that's probably better assessed with a MR arthrogram.
Yeah, I agree. I think that for those of us that use a lot of ultrasound, we would answer ultrasound to a lot of the questions, but I think for the purpose of the CAQ, if they give you another advanced imaging modality, that may be the answer to the question. Is kind of similar to, as we go along and there's more and more that we can do from a diagnosis and treatment standpoint with ultrasound, kind of look at it the same as with biologics on the board exam. I'm not sure it's gotten to the point where that it's going to be the most common answer to the question. So just wanted to ask that as far as if you had a sense of that as well. Any other questions from anyone in the audience? So I'll give a few more seconds to put one in there if so, but to be honest, Erek, I think you covered mostly everything. And I think all of the high yield information that will be needed for the boards is right here in this talk. So
Yeah, I may have rushed through
please review it.
I may have rushed through some of it, so feel free to, when you're reviewing it, press pause and spend a little more time on each slide.
Yeah, those the last couple slides that you had with just those images as far as how it broke down between sports and also location.
Oh yeah.
Maybe like those last two slides. Do you know where they can possibly find those, or y'all can take screenshots of these as well? But I think these are good breakdowns as far as, if you have a question and it's talking about particular sports, I think just having an understanding of which sports these injuries happen in can be a cue and a good clue for some of these questions that you might have as well.
Yeah. Okay, yeah. A few I left on at the end there that I don't think are necessary.
Right. Okay, so no other questions that are in there now. So we will wrap it up. It's a little bit after 9:30, so we'll wrap it up. Erek, thanks a lot for giving that talk. It was a ton of information, and again, I think super high yield as far as questions that are going to be on the board. So thanks again for doing it, for tackling a big topic. We appreciate it. And for everyone else, have a good night.
Thanks for having me, Robbie.